Hi, everybody. Welcome back to the Get Healthy Tampa Bay podcast. I'm your host, Dr. Carrie Reller, and today we have a returning guest, Dr. Jenna Kazil. Welcome back. How are you?
I'm good. Thanks so much for having me.
I know we already had you on the podcast, but why don't you tell us a little bit about who you are and what you do so we can refresh our memories, or in case somebody hadn't heard the previous episode on the peripheral vascular disease?
So I'm a double boarded vascular and general surgeon in Bradenton, Florida, as well as Sun City Center. And I pretty much do the skin and its contents. So everything from arterial disease, hernias, hemorrhoids, lumps and bumps, but also aneurysms, bypasses, things like that.
Awesome. Yeah. So if we need more details of your journey into medicine, we'll go back to the other episode. But thanks for coming back on the podcast. Today, we wanted to kind of go into another topic that you're an expert at, and that would be carotid artery disease. So what is carotid artery disease?
So I actually trained with the world expert in carotid disease. He wrote most of the books, most of the studies, Ali Abarama. And so carotid disease is blockages in the arteries in the neck. Now, those are the arteries that are kind of in the front right here. We have four arteries that go to our brains. We have the two in the back, the vertebral arteries, and then the two in the front. The common carotid breaks into the internal and the external. The internal goes into our brains. The external feeds our face. And so when you get blockages, especially along the internal carotid artery, those little pieces of plaque can break off and cause strokes. And so the whole point of treating carotid disease is to try to prevent strokes.
So how does it happen in the first place?
It's a combination of diet and genetics and lifestyle, really. Smoking is one of the worst causes, just like for PAD.
So how does it like build up in that area, and why is that area more vulnerable than maybe a different one?
So that area, they talk about low stress and high stress forces, and it tends to be a common place where plaque forms at that bifurcation where it splits off. And anything really from where the common carotid arteries take off from the aorta all the way up to the brain can embolize. So it's really important that we treat these areas, and depending on how severe the stenosis is, determines if there's anything that we really need to do or not.
So stenosis means like narrowing or blockages, right? And then we're talking about this
Correct.
plaque buildup that happens due to like the risk factors that you mentioned. And how do people typically present, or how do you even know that there could be a problem there?
So some people present with a transient ischemic attack, which is sort of, we would call it, some people call it a mini stroke. And that truly is what it is. There is some damage that's done where a little piece of plaque breaks off, goes to the brain, and people can't speak for a few minutes, usually less than 24 hours. So they can't move one arm or one leg, or their entire arm goes numb for some amount of time. And so they'll present to the hospital that way. The other thing that can happen is that they will have a complete or almost complete loss of vision only in one eye. And so we talk about those old school window shades that come down over your eye, and they'll go maybe all the way or just halfway and come back. And that's called amaurosis fugax. And that's evidence of a stroke. That's a
Mhm.
piece of plaque crossing the ophthalmic artery. And that's
It's
an
what?
indication. A piece of plaque
Oh.
crossing the ophthalmic artery. And that's a reason to get your carotid arteries at least looked at, if not fixed.
This would be a great episode to have a visual of like the anatomy in the neck, right? It says all these arteries are coming off of like the main ones, and I don't know if people really understand, but I think it would be really interesting to do that, but maybe next time. So you mentioned all these like signs and symptoms, but you mentioned the TIA, the trans ischemic attack. Now that
Mhm.
doesn't typically show evidence on imaging that anything happened. Is that correct?
Correct. Typically on an MRI, you're not going to see evidence of a stroke, but there is some, microvascular evidence that something happened at some point. There was some amount of damage, even though it's not something we typically see on imaging.
Hmm.
Some people have an actual stroke, which would be where you can see real damage to the brain, and maybe their symptoms totally go away, but they have evidence of damage on imaging. And some people have absolutely no symptoms whatsoever. And they may only have an abnormal sound called a bruit in their neck. So when I listen to all my patients, and patients say, well, nobody ever listens to my neck. And I listen to patients' necks. And if you hear a high-pitched wishing sound, I'll get an ultrasound and realize that from a diagnostic standpoint, a third of those patients have very severe disease, a third of those patients have mild disease, and a third of those patients have no disease. So it can be challenging to determine who really needs a procedure and who does not. So that's why we get an ultrasound as a screening test and go from there.
Mm-hmm. What's funny is I actually listen to everybody's neck too, and they're always like, "What are you doing?" Nobody ever does that. It's usually just maybe like the first time I meet them, or maybe one like a well visit or something like that, but not every time I see them. But it's one thing that could be easily picked up and missed. If you hear a loud sound, well, actually, why don't you explain what does that bruit or that sound mean that we listen like over the carotid in the neck?
The sound means that the blood is traveling faster. And specifically, it's very specific if you hear a diastolic bruit, that typically indicates that the stenosis is more than 90%. So if you hear that sound while the heart is kind of relaxing a little bit, that's very concerning.
Okay, I didn't realize that, but that's good to know. So you said a third of the patients would have severe disease. So what does that mean with how much blockage there is? What does that mean for the next steps? And obviously, you already mentioned the diagnostic thing is getting the ultrasound of the vessel, right?
That's the first step in diagnosis. And
Okay.
actually, Medicare requires an ultrasound for different types of procedures that we'll talk about in a little bit. So I see ultrasounds all the time. They'll say this patient has 47% stenosis. And really, when you look at the studies, you can go by plaquing, but we're really looking at the velocities, which is a measurement of how fast the blood is traveling. And the faster the blood travels, the more narrow the artery becomes. So these elevated velocities, it's typically less than 50%, 50 to 69% blocked, or more than 70 or more percent blocked. And that being said, even if it's more than 70% blocked based on ultrasound, I'm not fixing patients if they are asymptomatic, as in they've never had a TIA, they've never had any stroke symptoms, unless they are more than 80 to 90% blocked.
Okay. Wasn't there a previous like calculator thing that you put in for whether they have symptoms or not, whether you treat them, or I'm just thinking of like the MD calculator. Do you know what I'm talking about?
So typically with carotid disease, I will look at a couple different things. One is how functional is this patient? So I might have an 89-year-old patient, but in Sun City, they are playing pickleball, they're working at a local store, they're volunteering, they drive, they have a million grandkids, and they're very, very active, and they have 90% carotid stenosis. I'm going to fix them. Typically, in the past, we've said if we don't think somebody's going to live 2 years, that we wouldn't fix their carotid artery disease. Now, we're even saying 5 years if we think this patient isn't going to live 5 years. So your diabetic patient on dialysis who is wheelchair dependent and can't tell you what day of the week it is probably not an ideal candidate for an asymptomatic repair. But really any patient, unless they are too ill, so they have severe cardiac disease or their mental function's really totally destroyed from their stroke, we're going to fix even if it's symptomatic.
Yeah, those are important things to take into account, of course, like what the, quality of life and their longevity and everything like that. And explain why you aren't going to fix them. Like, what is the risk of the procedure? What are the procedures? And I know you want to go into all of that too.
So there's typically 3 different procedures that we talk about, and I'll go kind of from the oldest to the newest. So the oldest procedure is the carotid endarterectomy, and there's a couple different ways to do that, but typically you make a cut on the side of the neck about like this, and you dissect down to the carotid artery. You go right where it splits off into 2 different vessels, and the internal and the external, and I put some vessel loops around those. You give the patient a blood thinner, you open that up, you clean the whole thing out, and then I sew a patch on there. And that takes, for me, some patients, it might take 45 minutes, but typically for me, it takes an hour and a half to 2 hours by the time everything is said and done. And the biggest risk of any carotid intervention is stroke. So if you have someone who's never had a stroke, you need to talk about your risk of stroke. And the traditional numbers are around 11%, and we can take that risk down to 7% in about 2 years, which isn't really a huge change. So we really need to think about the risk and the benefit. For some people, the benefit is the anxiety of, I could have a stroke at any point, and I just don't want to have to think about this, and I can't handle it, and I just want this done. And they might be in their 50s or 60s, and that's very reasonable. The other risk, especially doing an open carotid surgery, is the risk of cranial nerve injury, which can cause problems swallowing. It can cause some numbness. Sometimes it can even cause difficulty using your tongue and speaking, or some facial drooping as well. And for more than 90% of people, this resolves within a year. But for some people, they can have a really hard time swallowing and eating, and that can be very challenging. And so you really want to, consider if that needs to get done. The next type of procedure that we typically think about that would be from a chronological order would be a transfemoral stent. So we put an IV in the leg, in the artery. We go up through the aorta backwards into the carotid artery, and we put a stent in there. And the thing about that, the biggest risk is your risk of stroke, which typically, I was taught is up to 10% for a symptomatic patient to have a stroke. Now, that might be a very small stroke where they have some mild numbness or weakness, or that could be a debilitating, they don't know what day of the week it is, and they can't speak to you kind of stroke. And so that's not something to trifle with. So we really want to make sure that if we're doing that type of procedure, there's a very good reason. The third type of procedure, which I would say for me is the most common and is my favorite procedure, is a TCAR, which is transcarotid artery revascularization. I was part of their initial study, the Roadster 2 trial, as a fellow, and I just really love doing these surgeries. They encompass so many of the things that I love about carotid endarterectomies and carotid stenting, and they're very safe. They are as safe, if not safer, than open carotid surgery. And so instead of making a big cut here, you have a very small cut, typically less than 2 inches, right over the base of the common carotid artery at the neck. And then you're going to reverse the blood flow. And you do that by going from a high pressure to a low pressure system. We put an IV in the leg, in the vein, rather than in the artery. And then we have some tubing and a filter system as well. And that prevents these little pieces of plaque from going to your brain. So we reverse the blood flow. And typically my clamp time, so the time without that side of the brain getting direct blood flow, because the brain is getting blood flow from the other side of the head because you're pulling it in the opposite direction, for me is anywhere from 4 to 8 minutes, which is super duper fast. And open carotid surgery, if you're truly clamping, for some people, it's anywhere from 20 to 45 minutes. I would typically shunt my patients and give like a little mini bypass during the procedure, but that's a whole different topic for another day, and a function of training and why and things like that. So it's very safe. It's very fast. I can do these procedures usually within 30 minutes, as opposed to a 2-hour surgery. You can do them entirely under local. That's not really my favorite way to do them, but it's certainly possible. So I think there's a lot of really great things about it. The most important for me is the neuroprotection.
Mm-hmm. So does the blood flow go back again, or is it permanently altered?
Yes. So once you're done with the procedure, it's restored to normal blood flow.
Okay. So it's just kind of rerouting it, or?
You're rerouting it. So you actually occlude the common carotid here, and you're pulling blood from here to this high pressure system to the low pressure system in your leg, which is the venous system. And you're blocking the blood flow from going up so that you can kind of pull all of that and any little pieces of junk, of plaque, instead of causing a stroke or going down into the filter.
Okay, got it. And then does the filter get removed?
The filter's all external. So then once you're done, you no longer are clamping the common carotid artery. You let that off. You take out the filter system. You disconnect it from the patient, and you're done. You close up and you're done.
You're basically cleaning it out, using the high pressure blood flow in the other opposite direction to take the stroke risk away.
Yes, but you're also putting a stent in. So that's how you're getting rid of the blockage.
Okay.
You're putting a stent in. Yeah.
Wow, I've never heard of that one. So definitely had, advances since I learned all this stuff. That's amazing. Really cool.
Really, the Roadster 2 trial that was going on in 2016. So we're talking about doing these procedures for less than 10 years, really, for most people. And they're really fun. They're really fast. They have some downsides, being that yes, you can do some reintervention with some balloons and other stents, but the stents are not the best thing for everybody. And you really need to look at that, and everybody's individualized.
Yeah. So can you outline and review what is the stroke risk with each of the procedures? Because I wasn't sure if you were talking about the stroke risk from the procedure or the stroke risk of not doing a procedure.
So for transfemoral artery stenting, a typical stent from the groin, if you are a symptomatic patient, so as in you have had a stroke previously, your risk of having a stroke from the procedure is up to 10%. Okay. That's really high. In a symptomatic patient, we talk about your risk of stroke from an open carotid surgery or even a TCAR being up to 6%. In my hands, that's much, much lower. And then there's a national registry where each hospital will list each surgeon's stroke rate for different types of procedures. So essentially, you have to submit all of this data. The hospital typically submits this data for you. It's usually called the VQI registry, but there's multiple different types of registries you could use potentially as a hospital system. And you want your stroke risk to be really less than 2 or 3% for all carotid procedures, especially the asymptomatics.
Wow. Yeah, I mean, that's great to get that. So, well, we talked about all the different procedures, but what about medical management? Like, do some cases just you're not going to do a procedure? I mean, I know that's
Absolutely.
but yeah.
Absolutely. So, in Europe, typically if someone is older, if we don't think someone's going to live 5 years, even if they have a high grade blockage, they're treating them with medications.
Mhm.
So these are things like statins, so rosuvastatin, torvastatin, which is, Lipitor, and then antiplatelets. And the two biggest antiplatelets we use are typically aspirin and Plavix. And depending on what other medical problems the patient has really determines what we're going to do and which medication we're going to use. So for instance, if I have a diabetic with PAD and he has carotid stenosis, I'm just going to leave him on Plavix and a statin. If I do a stent, whether that's from a transfemoral stent or a carotid artery, a TCAR, they're going to get aspirin and Plavix together for at least 30 days.
Okay. And then obviously prevention of it, you talked about the lifestyle factors, not smoking and things like that. Is there anything else that you would mention with that?
Blood pressure control is really important.
Mm.
So making sure those patients have an appropriate blood pressure, make sure that their hemoglobin A1C is appropriate. All of those things are super important, and not smoking.
What kind of blood pressure goal?
As a surgeon,
Yeah.
my blood pressure goals are typically much different than a primary care doctor blood pressure's goals. And that's, for me, if I can get anybody under 150, I'm happy. I know national recommendations are typically for diabetics. I think they're closer to 120 or things like that. But, less than 150 is typically what I'm looking for.
Nice. And that's what you're mostly focusing on the systolic then.
Correct. Yeah. But, I know that there's national recommendations for other patients. That's not, it's not uncommon for me to have patients walk into my office with a blood pressure of 180, 190, 200. And we talk about, hey, when's the last time you saw your primary care doctor? Do you see a nephrologist? Who's managing your blood pressure? What can we do about this? Because that becomes super dangerous.
Yeah, I mean, it makes sense, like a lot of your descriptions about the physics of, the vessels and the sizes and the pressure and the, velocity of the blood that's going through there. If we just think back to our basic physics and like plumbing stuff, it all kind of makes sense, right? Yeah.
Absolutely.
Yeah. Do you have anything else you want to mention about carotid artery disease?
I think it's really important that patients and other physicians referring these patients talk to their surgeons and see what their options are, because some people only do one versus the other, depending on their training. Typically, each hospital or each facility has somebody who's really good at doing transfemoral artery stenting, because you really don't want one person doing it. And the reason for that is that the more you do, the better your numbers are going to be, and you're kind of decreasing your overall risk. So it's very typical for some people to only do certain things. So for instance, I don't really do transfemoral artery stenting anymore, but I do a ton of TCARs and I do open carotid surgeries. So depending on which surgeon you go to, they may say, I only do this. I only do open carotid surgery. I only do TCARs. And I think it's really important that you make sure that you're looking at all of your options and why you're going to choose one particular procedure.
Yeah, that's definitely helpful, and helpful for me too, like as a primary care doctor, of who to send to and why, and maybe getting another opinion if needed.
Absolutely.
Yeah. Awesome. Well, our other fun topic was going to be aortic aneurysms. So why don't you explain what that means?
So aortic aneurysms are a dilation of the blood vessels. And so your aorta is the largest vessel in your body. It goes from your heart, it makes a big arc, and it goes all the way down to about your belly button, where it splits into your right and left leg, forming your right and left iliac arteries. And so an aneurysm, typically the ones that we think about, an abdominal aortic aneurysm is going to be in your abdomen versus a thoracic, which is going to be more in your chest. And anything more than 2 times the normal size, which, for most people is going to be around 2-ish centimeters, is considered an aneurysm. The typical size that we're fixing these is usually around 5.5. Just for some background, when I was in training, we weren't fixing these unless they were 6.5. And because of all of the endovascular options, which are now available, we're fixing them at a smaller and smaller size. Typically, it's around 5.5 centimeters. There might be reasons to fix somebody at 5, but typically it's around 5.5 centimeters. I tell my patients and I tell my primary care docs that around 3 to 4 centimeters, you want to at least be getting them to see a vascular surgeon, because sometimes it might take a couple months to get in. And the reason could be anything from insurance to time of year or how busy people are. And that's not an emergency by any means. However, you should start thinking about talking about, hey, you probably need to see a vascular surgeon once a year if your aneurysm is 4 centimeters.
Well, that's good information for me too. So what causes these aneurysms to form?
So 10% of these are genetic. And that's why any patient who has one, I will typically tell them that all of their first-degree relatives need to be checked for an aneurysm 10 years before they were diagnosed. So if I'm seeing a 75-year-old guy and fixing his aneurysm, I will tell him that any first-degree relative, so his siblings, typically his parents aren't alive, and his children need to be checked at age 65. So that's one part of it. The other part of it is high blood pressure. So again, the increase in pressure, decreasing wall thickness, and you get this dilation. And then, just due to physics, the larger it is, the more likely it is to rupture. So that's where we're typically fixing these, because we're trying to prevent rupture, and most ruptures result in death. Typically, when you talk about the rates of patients surviving a ruptured aneurysm, about half of those patients will die.
Just to go over what the symptoms are of a rupture in case somebody doesn't know, what would that be, so they can run to the
It's usually the worst abdominal or back pain you've ever had. And it's acute onset. It's not like, oh, I kind of ache. And it's usually just absolutely horrific pain. And realize that your abdominal aortic aneurysm, your entire aorta really is laying across your spine. So it's more so back pain than belly pain.
And so you said genetics and blood pressure. Were there any other people at risk for developing these?
Anybody who smoked more than 100 cigarettes. So, and men typically more than women. So those are really the biggest risk factors.
Yeah, and I would say, I think making sure that the primary care, is during like a well visit is doing those screening tests and ordering that, because we know that everybody who smoked and is male, and what is the age?
65.
We're supposed to be screening them.
So, male smokers more than 65, they need to be screened. Women with a family history who are heavy smokers, in my opinion, and have, those are also reasons to screen women as well.
And what is the screening test?
It's an ultrasound, which is pretty easy to do. Although some of my patients are so obese that you really can't tell with an ultrasound, and you can kind of get an idea, but you may miss something. And so then typically I'll get a CAT scan either with or without contrast, because you're really just looking at the size of it. Does this look relatively normal or not?
And so when does it become like a problem that you need to do something? I mean, you mentioned the size, but.
So size, but also the rate of growth. So let's say you have a patient in your office and they came up at 3.5 centimeters, and you go, we're going to get a repeat ultrasound next year. And now it's 4.2 centimeters. It's grown more than 0.5 centimeter in a year. That would be considered an aneurysm with rapid growth, and that would warrant repair. That or just the overall size.
And so is there medical management, or how does that work?
There's really not medical management. Once you get to a certain size, your options are to fix it, depending on how difficult the repair is going to be and what the risk is. Sometimes we wait to a larger size to fix it. So for instance, again, I guess this would be great where we had some pictures, but if the aneurysm involves the arteries that feed all of your organs, so your celiac, your SMA, your IMA, that's a much different repair than a traditional, easy, straightforward 2-piece endovascular aneurysm. You're talking about like a 45-minute procedure versus a several-hour procedure. Risk of need for dialysis, things like that is very, very different. So depending on what that looks like really determines when we're going to fix it.
So just to clarify, you're talking about if it's feeding like the abdominal organs and everything
How
like
extensive the aneurysm is, the way you fix it, you have to have, when you put your stents in, the stents need to land in healthy areas.
that.
So we have the neck, which is typically right below the kidney arteries. And then we need to have the end points down in the iliac arteries, which feed the legs. But if you have aneurysms along this entire area, now you really have to change the way you're going to fix it. Whether
Mhm.
that's using more stents, different types of stents, or is this going to be an open old school repair, which is a completely different animal.
Okay. Well, can you go over the differences of the repairs or procedures that we do to fix that?
Sure. So the most basic endovascular repair would be two little tiny holes about this big in each one of your groins, and we put IVs in there. And then I put a stent in on either side, and it looks like a pair of pants that sits right in your aorta, and it's a bypass from the inside out. That is the most basic, straightforward repair. Depending upon what vessels are involved, you can use more and more stents and different types of larger grafts to kind of cover your entire aorta from, your chest all the way down to your pelvis. And that becomes very, very involved depending upon what exactly is involved and how many different vessels and things like that. And typically, the more parts of the aorta that you cover, you're increasing your risk of complications. This can be anything from bowel death to paralysis, which can be permanent.
So what is the goal of putting the stent in?
The goal is to prevent rupture. And
So,
really, what you should be seeing when you get repeat imaging is the aneurysm sac itself should be shrinking.
right.
And we have pretty good data now that suggests that if your aneurysm is shrinking, you've done a good job and it's actually getting better.
So it's taking the pressure off of,
Correct.
cooling of in the aneurysm, basically.
Yep.
Okay. Awesome. So you mentioned paralysis and some other things. How do we
Yeah.
prevent all these things to happen?
This gotten really involved really quickly. Essentially, you really need to know what you're covering and why, and making sure that you're having adequate perfusion of the rest of your organs. And sometimes that's decreasing the pressure and putting in a spinal drain. And those are typically things that, if we think it's going to be that bad, I'm not doing that by myself at a community hospital. That's something I'm going to send to a tertiary care center where they can really have everybody available. You might go on bypass. There's a whole bunch of different things you can do.
And then, well, what about open surgical repair? Did you?
Open surgical repair is a big surgery. So typically for my endovascular aneurysm repairs, those patients go home the next day and they're walking around doing other normal things. And open aortic surgery, you're going to make a big, big belly cut from the bottom of your ribs, typically all the way down to your pelvis. And you're going to be in the hospital for at least a week. And it is a long recovery that also has a risk of damage to the kidneys, going on dialysis, bowel death, etc. Those are all the same risks that are involved.
Mhm. And which approach do you normally like to do?
Oh, endovascular. Everybody likes endovascular. It's gotten to the point actually where fewer and fewer people are doing open as far as training goes. And so they've decreased the numbers vascular surgeons need to be considered to be proficient. And so really in my case, the hospitals just don't have everything that we need for open procedures. And I'm sending those to tertiary care centers because I feel that the patients are going to do better.
Yeah, absolutely. That's kind of making it less risky for everybody. I think it makes a lot of sense. So if you have to do
100%.
care center, it's important.
And there's plenty of data that supports if you're not doing 10 of these procedures a year, and if your hospital isn't doing at least 10 of these procedures a year, you're going to have poorer outcomes than those that are.
Is there anything else you'd like to add about the aortic aneurysms?
Just make sure that people are getting screened. So I think the number one thing that I would tell patients is that if you have a family history, if you're a smoker, you need to be screened, and to bring that up to your primary care doctor because you guys are super busy and there's a lot going on. And that's probably low on your list of things to look out for, in addition to, high blood pressure and diabetes and high cholesterol. And so bring that up to them so that they can get the appropriate screening done.
Yeah, definitely very important with the genetic component, which I don't know if I was so aware about. So I think bringing that up to your doctor is going to be critical. Yeah,
It's
absolutely.
not a very large
Mhm.
percentage, but it is something. And then once you have one aneurysm, you're also more likely to have other aneurysms. So that could be aneurysms in the brain, that could be aneurysms behind the leg, that could be groin aneurysms, that could be aneurysms absolutely anywhere. And those all get treated differently than your
Mhm.
traditional infrarenal aortic aneurysm.
Why is it wait till 65 years old?
Those are national recommendations, and I'm sure it has something to do with the risk benefit and the number of lives saved. But realize that people get CAT scans now, or anything, any sort of
Mhm.
abdominal pain, people are getting scans. And a lot of the patients had a CAT scan for a kidney stone or a hernia or whatever it is, and they go, "Oh yeah, I have this aneurysm." Okay, well let's work on that first.
Hmm. Yeah, I mean, you're right. And there's so many other incidental findings, but this is definitely one that should be followed.
100%, yes.
Yeah, awesome. Well, why don't we, I don't know if we should cut it and do it next time, but maybe what I will do is say, I think, thanks for coming on the podcast. And I'm going to say, how can everybody find you? And then I think we'll go ahead and record the next time too for hernias, if that's okay.
Sounds great. So people can find me at floridasurgicalclinic.com and in Bradenton, Florida, as well as Sun City. And my office number is 727 surgery, which is 727-787-4379.
Awesome. Well, thank you so much. And everybody tune in
Thank
next week
you.
for next week's episode.